And here's Maya. We're going to talk about domestic violence. Here we have some pictures. Alright, what is domestic violence? Domestic violence is a pattern of abusive behavior and it affects all ages. This type of violence can affect heterosexual or homosexual couples and does not require sexual intimacy. It is a complex social problem. It is a major health problem and it affects all levels of healthcare, from the hospital to nursing home. The major types of violence are physical, sexual, and psychological.
We're going to talk about some myths that people have perception that this is what reality is, which is not. For example, first myth that a battered woman syndrome affects only a small percentage of population, and that is not correct. Actually, 4.8 million women every year experience some type of violence, and the biggest violence against women is battering, so the domestic violence. Next one is that violence occurs only in low socioeconomic classes and minority groups. This is also incorrect because it happens for any socioeconomic level. It's any class with any educational level and any ethnic group. Another problem is that it's really a partner abuse. It's a couples who assault each other, which is not true. It's actually for females. It's 95% of cases, women are the one who are battered. But also we have some other, we have cases where the men are the ones that are victims. Another problem is that, myth is that alcohol and drugs cause abusive behavior. They don't cause that behavior. Use of alcohol or drug, that's an illness, like alcoholism, or they're addicted, it's addiction. When it comes to the violent behavior, that is something that is learned and can be unlearned. So those two need to be separated from each other. And for example, that abuse is out of control and that's why he's abusing the victim. That is not correct. When it comes to abusing women, usually it is about power and control. And they're usually very in control because they exactly know when, where, and how, and who they're going to abuse at a time. The women or men got what he or she deserved. Sometimes that's perception and that is not correct and that is not true, and nobody deserved to be hit on either side. And women like it or they would leave. That is not true. Women usually don't, the women don't like to be battered. They're probably in some situations like they don't have enough financial good situation that they can survive without an abuser, or their children involved and they want to stay, have the children together with their father or mother. And couples counseling is a good recommendation for abusive relationship. That's a bad recommendation. It depends on each situation differently and usually can lead to further abuse if it's something like this suggested.
Right. Here we have some facts on 1 in every 4 women will experience domestic violence in her lifetime. As estimated, 1.3 million women are victims of physical assault by an intimate partner each year. 85% of domestic violence victims are women. Historically, females have been most often victimized by someone they knew. Females who are 20 to 24 years of age are at the greatest risk of non-fatal intimate partner violence. Most cases of domestic violence are never reported to the police.
And also, with this age, that is when actually our frontal lobe and our personality lobe is like finishing the development. So they kind of they're not sure exactly who they are and what decisions they need to make that are best for them. So after those ages, around 26, they kind of start realizing what is going on. And the best case scenario, after that age, women will possibly, hopefully, leave the abusive relationship. When it comes to ethical point of view, if we talk about, abuse does not fall under utilitarianism. If we think of what utilitarianism is, it's good for everybody, like doing good so that we promote good for everybody. In this case scenario, if a woman is battered, she is definitely, there's nothing good done towards her. And it's not just her, it's the environment, because children watch that behavior and they can learn it, and then they can be abusers one day if they observe this quite often. When it comes to the abuser himself, when it comes to natural law, sometimes there's that blurred line when they think that as a person they know what's best for that other person, and for sometimes they make it like rational that the abuse itself as an act is good for that other person, not taking that other person in consideration. So it's like the law, it's like he's stronger and he knows what's best for that abused he or she.
Basically, he thinks that other person have to live the life the way he wanted.
Yeah.
That's where everything comes. Here's the type of violence, and first we're going to talk about family violence and abuse. So intimate partner abuse. It includes physical, sexual, emotional, social, and economic abuse. Family violence of children. Not all parents with mental illness, learning disability, or who have experienced domestic violence or are drug alcohol dependent will abuse or neglect their children. However, these factors can considerably increase the possibility of abuse. And elder violence, usually done by close family members, young adults, and it's for monetary reasons. Basically, like Maya said, in the family violence of children, it's actually it's affect the children's life in the future because they're going to act the same way what they learned in the family. So if their father or mother is being an abuser, they're going to use that in their life. So there's more abusive people coming around. Here's a picture showing dad is shouting at a little girl.
And when we talk about violence community, we're just going to touch on it. We're going to talk about that is basically if there's some vandalism going on, or there's gang groups that are fighting each other, or protests going on. And children usually see that on TV or actually in their neighborhoods, depending where they live, and they take it to school, which actually develops that violence in schools called bullying, which is a major problem in the U.S. We're going to talk about also violence in workplace. That is something called, it's like side or parallel bullying. That is a person of the same equal or higher level of position at a specific job that is affecting the other person negatively. For example, if a nurse just starts a job, the nurse is in the same position, or their managers, they're treating them not as equal or not as valuable just because they're brand new nurses. And that actually led to a high number of nurses quitting within first year because they were not able to deal with that parallel bullying. Then we have that interprofessional violence within the profession itself, and they're also called horizontal or lateral violence. They're all within the same, it doesn't have to be at home, it can be just in the work area.
All right. We have a domestic violence and healthcare. So how the domestic violence giving care, is deal in the healthcare. So when we address the domestic violence, it raises important challenges to the healthcare system. So it challenges the healthcare theoretical model and the nature of medical training, the structure of funding and service delivery to the patient.
And when we talk about the barriers, and we talk about personal and social barriers, majority of providers, the problem is that they don't have a good training, like education, how to deal with abusive situations and how to go approach them. Gender and cultural differences are also big influence, because sometimes we have cultures that do not, in some cultures the women have to have like female doctors. And you wanted to share something?
Yeah, and basically where I came from, it's basically like we have that gender issue. So when we go to see a doctor and we want to see, for example, personally, I would say I want to see a female doctor. So
it's definitely
then,
based on gender.
yes, then only I feel comfortable talking to a female doctor everything than a male doctor. So I prefer a female doctor. So I'll be in that category.
So we need to be culturally educated as well, not just on training. And then abuse victim situation and their life stories might be psychologically very hard, and it can have an impact on a provider itself. So the providers also need to have that somebody to lean on in a professional level and at home to if there's a big stress at work from situations like this. And we have here basically like a circle of how everything connects from educational, gender, and cultural factors. We have individual level, organizational level, community level, and societal level. So it all starts with that one individual.
Okay. We have here systemic barriers and impact of theory on clinical practice. And one is impact of medical training. So gaps in medical education about violence influences various psychosocial aspects of care. Emotionally, distancing themselves from the patient situation providers might miss signs of domestic violence. Time-pressured working conditions only magnify these difficulties. So when the provider is emotionally distancing from the patient, it's very hard to understand what the patient is going through. Even though if I'm trying to tell whatever I'm going through, the other person, if they have a distance, they're not going to understand fully what I'm talking about. So that's that's one of the barriers to give a good care to the patient, what they expect. So here is continuing is a medicalization of social problem. So under this is HIV positive women either are or have been abused by partners, but that connections is often missed. And that is why, as medical providers, we need to investigate each case individually. Over here, the picture talks about over half of women living with HIV experienced IPV.
Which is partner violence.
Intimate partner violence, yes. And considerably higher than the national prevalence of prevalence among women overall.
And when we talk about structural constraints, which is with the system, we talk about cost. Number one, it's always a cost, because our providers as providers, they actually get penalized if they spend too much time with the patient or prescribing too many referrals. So another problem is micromanaging and insurances themselves. If the diagnosis is not listed in the patient's insurance policy, the insurance will not cover for it, and therefore if that person is hard socioeconomic status, they're not going to be able to afford it, and that will automatically make a barrier and they will not go and seek help. For victims in lower statuses, the only way they can get help would be through mental health services, which funds are, as we know, constantly shrinking. And so in order for them to get any type of help, they have to get a diagnosis that is, for example, PTSD from the abuse. But if they get the PTSD, that means that they are automatically labeled as they are mentally disabled, which can lead to other difficulties, like it can possibly let them, they can lose their children over that type of issue. So there's not a clear way how to approach this problem. There's not a domestic violence diagnosis that providers can use and insurance will take.
Here we have a scenario that we're going to talk about. That video is from United Kingdom, so we have a USA helpline right here. We have included, and we'll talk about the cycle of violence in a little bit. There you go.
So when you have the cycle of violence, what Kaya was saying, it's actually a never-ending cycle, and it starts with that tension building. So, for example, the couple they started dating, and then all of a sudden he just becomes moody, or she, and then he started just feeling very anxious, and maybe starting to show some aggression, and it's building when he actually does do the violence and become violent towards a woman or a man. And after that, depending how harsh that violence is, we have that honeymoon phase where he's apologetic, he's explaining he's sorry, and the main thing that will never happen again. And as healthcare providers, we try to teach them that is usually not true according to evidence-based practice. So that honeymoon phase is like the makeup stage, and then everything is going to be better, and a woman stays because of that honeymoon stage. That's why the woman stays in their relationship. But that usually doesn't last long, and then the build-up stage again emerges, and then it can lead again to the bullying that can eventually be fatal.
When we assess the violence, so when there's a patient comes has been abused, the best thing is that we have to isolate the potential victim and talk to him or her privately, because when the abuser close to them, they are not going to tell everything what is going on. And observe their body language when around potential abuser and privately. So when the abuser around, we have to check their eye contact and the body languages and how they react to a situation when the abuser with them and without them. Assess for bruises of different stages of healing which would indicate potential abuse. So we actually need to check all the bruises to see what stages they are, and to see how potential abuse. Assess for the extent of violence, how many years it's been going, and what type of violence, and how did it start. Use therapeutic communication to maintain nurse-patient connection. Silence and nodding, we had to give them time to tell us what is going on, and give time to process information to tell us the whole story.
And interventions that we're going to use are based, of course, on each individual person differently. So we have to assess what their knowledge about the abuse itself, and do they even acknowledge it as an abuse? Are they approachable or not? Because sometimes that we just cannot intervene, we cannot give them any information if they are strongly against it. So we have to know their perspective of it, and if they're not for the immediate intervention, physical intervention, we can supply them with like material, like phone numbers and shelters and services that can maybe call and talk to somebody at the beginning, and maybe from there they can move on and maybe move out and get out of that situation. And then from this information that we get from the patient, we can actually drive that escape plan, and we always want to include them in it. Like, we don't want to give them a scenario, we want them to think about it. We want them to give us example if they have a cousin or sister or somebody that they can actually take their stuff to, and they have to tell us how would they do it, because that way they can actually create plan just talking about it, and then plan will stay on their mind.
Then I'm going to add some, because we have to include them because they know their house and the situations, what time and what kind of situation it's going to be. It's usually how it's, and that will make it easier to make the plan. So they know what time is a good time for them to be go out, or what is quiet time when that abuser is in the house or when they are not in the house, and how they can escape from the house. So all this, they know better than us. So we have to include them to make the escape plan.
And we're gonna show a video, and it's, this gentleman is explaining about Clare's Law. This law happened because a young woman named Claire Wood in the United Kingdom, she met somebody on Facebook or social media, and she actually, on the profile, he had this story about him that was very good, and she met with him, and they dated for a while, and after a while, she saw his real side when he became abusive, and actually, when police went later, he had a serial of complaints against him from previous relationships, and they were dating. In that dating, he became abusive. She broke up with him, but he kept coming back and beating her, abusing her. She called the police. Police reports were filed, but never connected to each other. And eventually, he actually raped her, murdered her, set her body on fire, and then hung himself. And because of all that situation, the family of the victim contacted the local legislator, who actually passed this to the higher up, and they passed a law in March of 2014 about Clare's Law, and he's going to explain briefly what Clare's Law is about.
Clare's Law is open to all members of the public. It was implemented into Essex Police on the 8th of March 2014, and it's a process that allows members of the public to make an application to establish whether they or somebody they're concerned about is at risk of domestic abuse from a partner. The right to ask process is specifically for members of the public to contact the police, whether that be through the 101 number or through their attendance at a police station. It allows them to come in, provide us with some details, and for us to conduct some checks on the details that they've provided us. We will then assess through a multi-agency forum whether that person is at risk of harm at all, and we'll look, if they are, then we'll look to make a disclosure to that person to help them get out of that abusive relationship. The right to know process places a huge responsibility on Essex Police for us in our everyday business. When we come across intelligence or information to suggest that somebody's at risk of harm, place that responsibility on us to make that application internally and to make that decision as to whether somebody is at risk of harm, and for us to proactively make a disclosure to that person to help them identify the risk that they're at and help them in a supportive manner to make decisions around their future. I feel it gives them the ability to make decisions on their relationship, whether they want to stay in that relationship or whether they want to come away from that relationship. For those people that want to come away from that relationship and move on and no longer be the victim of crime, Essex Police will help support them through that process, along with the assistance of our partner agencies. We'll provide them with information and support to guide them through that process, which can be a very difficult time for people. For those people that choose to stay in a relationship, it also provides them with really important information in relation to the risk they're potentially exposed to and how they can safeguard themselves going forward. And again, we can provide them with the right support, the right details of partner agencies and other supporting networks to help them through the process. We're trying to receive feedback from people that we've disclosed information to see whether the benefits of the scheme, as I see it, are actually working and being taken into consideration by the people that are receiving disclosures. So we're in the process at the moment of actually going back and revisiting some of those people that we've disclosed information to see what the benefit of that disclosure was to them. Early indication is that it's been a real positive scheme and a real positive process for those people that have come in and made applications, and actually those people that we disclosed to them as part of the right to know process without them even being aware that we were going to do so. So the feedback at the moment is really positive, and we're going to look to continue to develop that liaison with those people that we've disclosed to.
What this gentleman explained was that this law allows people to know about the people they're getting in a relationship with, male or female, and they give them an option. If there's a dark background, they still have an option if they want to be part of the relationship or not, and it's on them from there on. And it was very interesting because one of the other interviews, the actual father of the victim, Claire Wood's father, he was interviewed, and he said that it all started, yes, it starts from the daughter because she was complaining, but the problem was the misconnection between the systems from one police station to another. There was never a connection made that that person was battered again and again and again. And he said that if with this law, we're going to know one thing. A lot of times we're going to look at what police missed. This law was made because somebody is dead. And then what's going to happen afterwards We might not have exact amount, and it might take time until we have the gathered information how well this law works. But this was started with somebody's death, and we're hoping that some of the laws that are going to be passed are going to be based on some rational data and not on some sort of tragedy like this was.
Right, now we're going to talk about ethical side of the Clare's Law. Promotion of utilitarianism with a goal of greatest good for the greatest number of people. Possible invasion of privacy due to emotional rather than intellectual motive behind the law itself, meaning it was driven by emotions of the victim's family. Do you want to add something?
Yes, like that could be a possible problem, and some people, when they were trying to pass this legislation in the UK, people are complaining about it, and actually the father of the victim was there. He stood up and literally slammed his shoe on the table, and he said, "Why don't you come and walk 1 mile in my shoes and see how painful this process is for me and my family?" Yes, it's emotional, but behind it, it's just a rational thinking to prevent this type of ordeal happening ever again, or at least decrease the amount. We want this law passed to protect people.
It's actually a good thing.
Yeah. And our conclusion is that as nurses, we need to focus on our patients' best interest, because we're advocates for them no matter what age or social level they are, what race, educational. We can never assume that a person was better or not better because of where they come from. We have obligation to do everything in our power to be supportive, informative for our patient, but we have to know our limits, because sometimes patients are not going to be accepting of that, and we have to exclude ourselves emotionally. It might be hard for us, but sometimes we cannot predict the outcomes of our intervention. Sometimes a person will get out of the relationship and think about it and maybe never get in an abusive relationship again. Sometimes this can lead to death, and we have to be prepared that we can only control ourselves, and our patients are, they only do what they think is best for them. And because we're the only voice, that's why you have to listen. We're ultimately, we can be between the doctor. If the patient doesn't want to talk to the doctor, we're with them most of the time as nurses, and we're there the only voice sometimes when it comes to talking about violence.
Okay, we have our references, and thank you for watching our presentation.
Have a good day.